طيب السلام عليكم ورحمة الله وبركاته. Good morning everyone. Thank you so much Dr. Mariam for the nice introduction and the kind invitation to present in this prestigious forum, which is honestly very amazing so far. So without further ado, I'm just going to start my presentation. I have no disclosure related to this talk. Just going to start with the case. So I received a call from a friend of mine who's a rheumatologist. Apparently he trusts me. So he called me that I have a patient. I don't know what's wrong with her, but I do believe she's having some cardiac issue. And after the call, I was like, listen, I only have 10 minutes. I really have to get into this. So can you send her to my clinic and I'll see her? If I trust you. If you think this is cardiac issue, then inshallah I will deal with her. So when I saw her in the clinic, she's a 54-year-old female with hypertension, hypothyroidism, and RA-PMR, which is rheumatoid arthritis, polymyalgia rheumatica. No other cardiac risk factors. She's been complaining of exertional dyspnea and fatigue for a few months. She's now at NYHA class 3. She has PND and orthopnea and leg edema. So her physical exams, basically her weight is 63, blood pressure is 135/70, heart rate is 90, sitting well. GVB is elevated with bilateral beating edema. And not surprisingly, this is her labs. Hemoglobin is 12, creatinine is 65, potassium is normal. She's not diabetic, and her pro-BNP is elevated at 3,500. So this is not surprising to me, at least, knowing her history. As you can see, she's having severe LV systolic dysfunction with significant MR. But this is actually shocking to me when I reviewed her medication. She's taking more medication than the minutes I was given. It's too many to carry. That's why she brought the list, actually. Usually our patients bring the medication in a bag. This patient, because of all these medications, she just brought the list in Arabic. So this is not good. So I told my team, well, the mission is probably not impossible. The mission is possible, and we'll make it possible with your help. So our mission is to convert all the polypharmacy she's taking into the 4 pillars that will prolong her survival. And I like to call them the Fantastic Four. So clean this polypharmacy, and this is the goal, to the pillars that we need to. So as you know, all the guidelines recommend the 4 pillars. So this is the EEC from 2021, recommending the 4 pillars, which are ACE inhibitors, ARNI, beta blocker, MRA, and SGLT inhibitor, as class 1 recommendation, with diuretics being used for volume overload. Similarly, the American used the same thing in 2022, instead of vertical, being horizontal. And in our guidelines, the 2023 National Heart Center, Saudi Heart Association heart failure guidelines, again, we recommended these 4 pillars for patients with HFrEF, similar to our patient. So basically, ACE are ARNI, beta blocker, MRA, SGLT inhibitors, and diuretics as needed, and titrate them to maximal tolerated dose. And why is that? I like this analysis because it really provides us as a treating physician and patients with very comprehensive data. So this is basically comparative analysis using 3 randomized clinical trials in patients with HFrEF. So basically they try to estimate the lifetime benefit of using such comprehensive disease-modifying pharmacological therapy. Similar to the medication she's using for rheumatoid arthritis, these are a disease-modifying treatment. So they use data from the Emphasis trial using eplerenone, data from Paradigm HF using ARNI, and data from DABA HF using SGLT inhibitor. And getting all these data, they were able to estimate that if the patient use such comprehensive therapy using the 4 pillars we just mentioned, compared to traditional therapy, patients will gain 8 additional years. Again, this is in keeping, as we heard yesterday, from the Vision of 2030, increasing the average age of the population. So, and I like to use such information to convey to my patients with the polypharmacy that these medication, if you use them, inshallah, we will prolong, inshallah, your life by additional 8 to 6 years. So here where the magic comes, Now we have to convert her polypharmacy to the pillars. So the X-Forge was switched to Arni, bisoprolol, and aldactone. We added dapagliflozin, and I have to mention this sentence every time I give it to my non-diabetic patients. I know you're not diabetic, but this medication works for heart failure, even in non-diabetic patients. And even if our colleagues from pharmacy told you not to, please take it. So we used virtual uptitration. I'm going to hear more about in the next talk about virtual clinics and uptitrating such GDMT to target doses. But to do this, you really have to give the patient discounts. It's the season for discounts, Black Friday, and whatever you want to call it. So we start to clean the list. Give the patient, we're going to add 4 pillars, but please remove some medication. So how about statin? She's non-ischemic. We did a CT angio. There is no ischemic, no. And I use this nice National Heart Center ASVD risk estimator, which is a very interactive tool. I really like it because this was done for Saudi population by the National Heart Center. And I calculated her risk and came to 3.1, which is a low risk. So she doesn't need statin. So first drug to be removed was statin. As you saw the list, she's taking a lot of garbage medication, I like to call, vitamins and supplements. And if you go with the guidelines, it's class 3 to give such medication. There's no benefit for multivitamins or nutritional supplements that most of our patients takes in their polypharmacy. And she's taking non-steroidal anti-inflammatory drugs, and it's class 3 because of harm. So we stopped all these vitamins and non-steroidal anti-inflammatory drugs. Always think about non-pharmacological things. It's class 1 recommendation to use a multidisciplinary team for uptitrating medication and educating the patient about the importance of these 4 pillars. Also, this season of flu vaccine, so it's class 2A to give the patient flu vaccine, which we did. Always think about the psychological impact of heart failure. It's class 2A to engage the patient, screen for depression, social isolation, and frailty, which is very crucial. And it really helped our patients since she's having rheumatoid arthritis and heart failure as well. Lastly, but not least, it's cardiac rehab program. It's class 1 recommendation to engage patients in regular training and exercise and enroll them in cardiac rehab program, which we did. So fast forward, present for the progress, 3 months later, our patients now feel much, much better. She's very active with regular exercise. She's happy. She's at NYHA class 1 to 2, no orthopnea, no PND, no leg edema. And this is her medication now. So we stopped pantoprazole because she was taking pantoprazole because she's taking polypharmacy. She's taking a lot of medication. That's why she's having the symptoms. That's why she's taking the pantoprazole. So we stopped that. Her IPS improved thanks to all the things we did. So we stopped the IPS medication. The X-Forge we changed to the 4 pillars. I negotiated with the rheumatologist to stop the cortisone because she felt much, much, much better now. She's able to mobilize with physiotherapy and cardiac rehab. We stopped the statins because she's low risk. We stopped the vitamins. We stopped the non-steroidal. We stopped the calcium. Too many things she was taking were really garbage. Too many things we stopped and replaced them with the 4 pillars. And not surprisingly, this is her echo now. She improved her ejection fraction to low normal, around 50-55, and her MR improved significantly. So I spared her from the next talks. She doesn't have to go to Dr. Faisal or Dr. Msaad or Dr. Fahad for ICD implantation. So no device, alhamdulillah. So you don't have to debate my patient. So in summary, in 2024, we have foundational 4 pillars that improve survival of patients. However, we struggle with polypharmacy due to comorbidities, as we saw in our case. So multidisciplinary team has a crucial role and patient engagement as well in trying to implement such pillars and getting rid of all the polypharmacy that the patient will not have any benefit from. And always don't forget that there are non-pharmacological interventions that are known to prolong patient survival and improve their symptoms. And I'm on time. Thanks.